Welcome to Ask the Expert, featuring leading neurologist and muscle physiologist Dr. Stephen Cannon, answering some of the most often asked questions from our website and social media channels. Remember, the content in this video is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician with any questions regarding a specific medical condition. Today's question comes from Kathy G. I am at my wit's end. I live in rural Montana and have been to the emergency room several times with my 15-year-old daughter, who becomes paralyzed, usually in the mornings and after cheerleader practice. One young Asian doctor on duty in the ER when she was taken from her school by ambulance brought up the possibility that my daughter could have periodic paralysis and that there are many different types of this disease. There is no neurologist in this part of Montana that we can find who knows anything about periodic paralysis. Could you please explain periodic paralysis to me and tell me why there are so many types and what makes them different? Thank you. Kathy.
The essential feature of periodic paralysis is repeated episodes of severe weakness. That's it. That's the critical feature. There can be other accompaniments which can be very important to distinguish which type of periodic paralysis an individual might have, but the essential feature is I get weak, it's severe, it can affect parts or my entire body, and it keeps happening over and over again. That is the essential feature of periodic paralysis. For example, the attacks of weakness often come first thing in the morning. So individuals may have trouble getting out of bed. They're awake, alert, have difficulty rolling over to hit the alarm clock. It takes 5 or 10 minutes to get their strength together to be able to get up and walk across the floor and go to the bathroom. Once they get there and walk around and make it down to get a cup of coffee, things are a lot better. That's periodic paralysis. Weakness that is severe, significant to the point where it affects function. You can't do real-world common things. Difficulty getting dressed. I can't stand up. Walking up the stairs would be extremely difficult. That's the severity that can occur. Amazingly, the severity of these symptoms fluctuates, not rapidly, but over minutes to hours. And so soon individuals will begin to have strength return and things will be almost normal. Sometimes you don't get quite back to 100%, and the individual can tell you, I don't quite feel right, although to your family members or your employer, things may look normal and you function well enough to go to school, to go to work, but you know you're not quite at 100%. So there can be these lingering features, but the hallmark, the tip-off, what lets people know I might have periodic paralysis are these episodes, these punctate episodes where I am having literally an attack. This is severe. I am much weaker than I was earlier today or yesterday. This is abnormal. I can't function. And yet, over a matter of minutes to hours, I get better. So an important point is it doesn't have to be full paralysis, flaccid, unable to move. It can go all the way to that point, but not every attack will be the same, and it doesn't have to be that severe. Usually, when the diagnosis is secure, it's an important level of weakness, though. It affects function. It's not just, I don't quite have the right energy, I'm a little fatigued, I'm not at 100%. It's to the point where I would be worried picking up my infant and carrying. I'd worry I'm going to drop my child, or I can't carry this tray in the cafeteria. So it's significant, and individuals recognize that. So while repeated episodes of weakness is the defining feature of periodic paralysis, it's important to recognize that there are many forms of the disease. And these forms have been given names in relation to changes in the potassium level that occurs in blood. So this has been recognized as long ago as back in the 1940s. So in one form of periodic paralysis, the potassium level in the blood is abnormally low during the attack of weakness. It's not a problem maintaining your blood potassium, but when the potassium goes low, if you're susceptible, because of a genetic predisposition, your muscles will become weak and associated with this low potassium level. The fancy medical term for that is hypo, meaning low, kalemic, meaning potassium in blood, periodic paralysis. So hypokalemic periodic paralysis is the official name. Many call it Hypo PP for hypokalemic periodic paralysis. This is the most common form of inherited periodic paralysis. Probably accounts for about 60% of documented cases of familial periodic paralysis. It's a dominantly inherited disorder. So as a parent, you have a 50-50 chance that your child will have the condition, and it runs in families. This is another key to establishing the diagnosis. So while these are rare diseases, the fact that someone keeps having repeated severe episodes of weakness is unusual. And if it's happening in multiple family members, that's even more unusual. And that will really help a physician understand we're dealing with a genetic disorder here, and this will start the light bulbs going off that periodic paralysis should be a diagnostic consideration. So that's hypokalemic periodic paralysis. Another interesting aspect is that because low potassium is associated with these episodes, events that cause potassium in the blood to go lower in all of us, not just people with hypo-PP, but in all of us. If you eat a bunch of sweets, if you eat pasta, carbohydrates, eat a candy bar, the sugar in your blood causes insulin release for the sugar to be taken up by the liver and the muscle. And when this happens, potassium ends up moving as well. And that will drive the potassium low. So this is why individuals with hypokalemic periodic paralysis can have episodes of weakness triggered by eating sweets or carbohydrates. And so individuals avoid these activities to minimize the likelihood and frequency of these attacks. There are other life events that can cause the blood potassium to go low. Again, this happens in everybody. Not everybody gets weak, just the susceptible people with the gene defect in hypokalemic periodic paralysis. So diarrhea or vomiting or excessive use of diuretics or actually licorice intoxication, eating a lot of licorice, all of those things can cause a loss of potassium from the body, in the urine, in the stool, in vomit. Losing those large amounts of potassium will be a risk period for triggering secondary weakness in hypokalemic periodic paralysis. A final triggering event that many individuals with this disorder have recognized is that adrenaline, the release of adrenaline, causes potassium to move into cells. This is part of the normal biology that all of us use in the so-called fight or flight response. I need to get up and run away from that predator lion or what have you. And the way this hormone works, it causes a lot of changes, metabolic changes inside your body, one of which is potassium moving into cells. So stress, emotional stress, physical stress can be a trigger for an attacks of weakness, but also little amounts of adrenaline, epinephrine, is included in many injectable medications. So like in Novocaine or other injections, because adrenaline causes local constriction of blood vessels and helps control bleeding for medical procedures. So individuals with hypokalemic periodic paralysis want to make sure their physicians know and to avoid epinephrine or adrenaline containing medications if possible, because that could trigger an attack of weakness. So that's hypokalemic periodic paralysis. Another form was subsequently recognized, again, not immediately from things the patients could tell healthcare professionals, but from doing blood testing. It was recognized there's a second form of the disease where during attacks of weakness, the blood potassium is too high. Just the opposite, not too low. As well as the potassium spontaneously being high, if these individuals ate high potassium containing foods, that could trigger an attack of weakness, or fasting for prolonged periods of time. So while as eating these snacks and carbohydrates lowers potassium and is bad for individuals with hypokalemic periodic paralysis, with fasting and skipping meals, your potassium blood level tends to go high. And so that can be a problem. So individuals with hyperkalemic periodic paralysis can actually benefit from snacking on sweets intermittently to keep their potassium from going high. So it's well recognized that understanding which type of periodic paralysis somebody has, which type is running in your family, will change the recommendation of how to best avoid recurrent attacks of weakness by simple things like modifying your diet or which medications you might want to take. There's another very important difference between hypokalemic periodic paralysis and high blood potassium periodic paralysis. In hyperkalemic periodic paralysis, where the potassium levels are high in the blood, there's another associated muscle problem. Doctors use the term myotonia, muscle force. In this situation, there is involuntary, persistent contraction of the muscles. So it's kind of just the opposite. Instead of my muscles won't work, I'm weak, I can't make them do anything, they're just sitting there, I have trouble relaxing after a voluntary contraction. So somebody stands up quickly, gets up out of a chair, and their legs are stiff. It's hard to walk because you're stiff. Or after clenching a fist, it's difficult to relax. Or going out in the bright sunlight and squinting your eyes, the eyelids get contracted and won't relax back. This involuntary, persistent activity of the muscles, it's a muscle problem, is called myotonia. And it's because of excessive excitability of the muscle. The problem is originating in the muscle. And importantly, this can be in an accompaniment with hyperkalemic periodic paralysis, but does not occur in hypokalemic periodic paralysis. In fact, this activity-dependent muscle stiffness is often used as an exclusionary factor to make a distinction between hypo and hyperkalemic periodic paralysis. So it's an extraordinarily useful observation to make. Hyperkalemic periodic paralysis is a well-recognized form in which the blood potassium is high, and the key feature is that it is often associated with this involuntary myotonia or muscle stiffness. There's another variant that has a combination of myotonic stiffness and episodes of weakness or periodic paralysis. But in this variant, the myotonic stiffness predominates. So these individuals are most bothered by stiffness that is prominent with the first attempts at voluntary movement, or in some individuals, the stiffness is dramatically worsened by cooling. They may also have episodes of weakness as well, but because stiffness is the predominant feature, this collection of symptoms has been given a different name. It's been given the name Paramyotonia Congenita, which is a type of periodic paralysis. The words Paramyotonia Congenita refer to the fact that paradoxically, the myotonic stiffness becomes worse with repeated muscle activity. In other forms of myotonia, repeated activity lessens the myotonic stiffness. When it paradoxically worsens, it's paramyotonia. The term congenita is because affected individuals become symptomatic at a very early age, often infants or toddlers, so it's a congenital disorder. So Paramyotonia Congenita refers to this myotonic stiffness, early onset, often aggravated by cooling or repeated muscle activity, and also associated with recurrent episodes of weakness. So it is a bona fide form of periodic paralysis, most similar to hyperkalemic periodic paralysis, with a lot of overlap. The management and treatments for the two disorders are overlapping, and individuals should recognize that Paramyotonia Congenita is another variant of hyperkalemic periodic paralysis. So every form of periodic paralysis has recurrent episodes of weakness as the cardinal feature. There's another type of disease, Andersen-Tawil syndrome, which is a form of periodic paralysis, the only form of periodic paralysis in which tissues other than skeletal muscle are affected. This is because the gene defect occurs in heart and in the skeletal system as well as in muscle. So these individuals have recurrent episodes of weakness, but also irregularities of the heartbeat. So the electrocardiogram is a little bit abnormal all the time, and the cardiologist can pick up on this and help make the diagnosis. This also causes a susceptibility to irregularities of the heartbeat that can actually be life-threatening and cause things like fainting spells or even death in rare instances. The defect also affects channels in skeletal system, and so bone formation from birth is abnormal. So individuals have short stature or curvature of fingers or distinguishing features in the shape of the face that is characteristic of the syndrome and helps with the diagnosis. So this is the Andersen-Tawil syndrome, where the defect in the muscle itself shares many of the same features in terms of the fundamental biology with other forms of periodic paralysis. That's why the symptoms, what the patient feels, is very much in common with the other forms of periodic paralysis, and it belongs in the same family of diseases. But here, the big difference is the underlying defects affects multiple tissues, not just skeletal muscle. And that's why there's a heart and a bone involvement as well in the Andersen-Tawil syndrome. Like periodic paralysis, the presentation is highly variable. So in one family, an affected individual may only have episodes of weakness. A different family member may have episodes of weakness and irregularities of the heartbeat. A third family member might have curved fingers and an irregular heartbeat, but no episodes of weakness. This is just the biology of the disorder. It turns out that one of the easiest diagnostic tip-offs in the Andersen-Tawil syndrome is the signature of the electrocardiogram, the electrical test of the heart that you have in the outpatient setting. Because of that, there's a bias, a detection bias. Most individuals diagnosed with the Andersen-Tawil syndrome are a consequence of the effects on the heart. So there are many individuals in whom the primary manifestation is actually a muscle problem with weakness, and they are undisclosed yet. They may have underlying rhythm problems of their heart, but it just hasn't been picked up yet because they haven't had the electrocardiogram. The episodes of weakness in the Andersen-Tawil syndrome are most similar to hypokalemic periodic paralysis. So individuals find out that eating carbohydrates can trigger attacks, or potassium supplements can help prevent attacks. And so if something appears to be hypokalemic periodic paralysis, you might actually have the Andersen-Tawil syndrome. And this is an important consideration that your clinician needs to be aware of and to test the heart with the electrocardiogram. There is another form of periodic paralysis called Thyrotoxic periodic paralysis, or TPP. The name is applied because these episodes of weakness occur in association with an overactive thyroid gland. That's the small gland in your neck that might swell. In goiter is the common term that's used. When the thyroid gland is overactive, people have weight loss, sweating, hair changes, diarrhea, nervousness, tremor. These are all symptoms of thyroid disease, hyperthyroid disease. A subset of individuals in the hyperthyroid state get repeated episodes of weakness. And in fact, during these episodes of weakness, their blood potassium is low also. So when they go to the emergency room with weakness that came over minutes and lasts for hours and keeps coming back, the blood potassium is low, and this looks just like hypokalemic periodic paralysis. The key difference is they also have hyperthyroidism. This disorder, for reasons we don't understand, is far more common in Asian males. So particularly in individuals from Japan or mainland Asia, males in their 20s and 30s with thyroid disease have a very high risk of episodic weakness being a feature of their thyroid disease. So this needs to be on the radar screen for every treating physician who's trying to help an individual with might be even recurrent episodes of weakness, but in association with thyroid disease. The clinical manifestations of thyroid problem, the elevated heart rate, the diarrhea, the weight loss, might not be dramatic. the thyroid disease might only be detectable with a blood test. So it's important, if somebody goes to the emergency room with repeated episodes of weakness, maybe in association with low potassium, especially if there are no other members of the family affected, that the possibility of thyroid disease be considered and a thyroid test from the blood be performed. In every case where this is thyrotoxic periodic paralysis, where the weakness is because of the thyroid problem, the thyroid disease is detectable. In other words, if your thyroid blood tests come back normal, you've essentially excluded thyrotoxic periodic paralysis. You cannot have a normal blood test and still have a diagnosis of thyrotoxic periodic paralysis. So statistically, worldwide, this is actually the most common form of periodic paralysis with repeated episodes of weakness. It's in a gray zone because it's almost a secondary form of periodic paralysis because it occurs in association with thyroid disease. And the definitive treatment is just cure the thyroid disease. When the endocrinologist fix your thyroid disease, that's it. The periodic paralysis will end. It does not come back. So this is primarily a diagnostic consideration to get your thyroid fixed and be done with it. But it's an important part of the differential diagnosis that clinicians need to have on the checklist because you certainly wouldn't want to miss it. It's curable. Just fix the thyroid disease.
If you would like to know more about periodic paralysis, visit periodicparalysis.org. And if you enjoyed this video and want more, hit that like button, subscribe to our channel, and hit that bell so you don't miss any future videos. It really does help spread the word. You can view other videos about periodic paralysis by clicking the thumbnails to the right. If you have questions, just leave a comment below or reach out to us on social media. We'd love to hear from you.